This is for Dr. Ramirez. Would you recommend everolimus to be given with lanreotide when growth of nodules starts increasing?
So that's a very good question. Now we're still trying to figure out the use of lanreotide in patients with neuroendocrine tumors of the lung. We tend to think that it may be beneficial, but yes, I would use the two in combination.
Thank you. This is for Leanne. Any suggestions for easy snacks for when you're away from home?
Away from home, sometimes just peanut butter crackers, if you're tolerating fats or if you're taking a medicine to digest fats, can help you. I think that trying to find, or maybe even taking things with you that are low in fat is the biggest. Try to stay away from nuts or foods that are fried is the easiest. Tuna in a little can is easy to carry and can be carried in your purse very easily and taken with some crackers. And that's a real easy one. And then fruits that are easy to absorb can also be used. String cheese is low as mozzarella. It's a low fat usually, and that's easy to take with you as well.
Thank you. And here's another one. Actually, anyone can help Leanne with it. Can anyone explain amines in food and how they affect nets?
The what in foods?
Amines.
Amines? They are what is broken down in the aging process of foods. So that is produced from the smoking, the curing processes, foods that as they ripen, they're going to produce these. The pickling, soy sauce, fermentation, and alcohol. That's why distilling and alcohol fermenting, these all produce amines. And the amines are what's usually involved in the flushing.
All the panelists, you are truly amazing. Thank you for your commitment to the patient and your profession. Does anyone know about Ex Viva for bone mets? How about Lowell?
Ex Viva is a drug that denosumab is the other name for it. That's indicated for bone metastases. The main concern that we worry about this class of drugs, along with the bisphosphonates, some of you may have heard of Irradiation or pamidronate or zoledronic acid, Zometa, that's zoledronic acid. We worry about osteonecrosis of the jaw. So tooth health, teeth health becomes the major concern when we talk about denosumab or the bisphosphonates. So they're indicated. Usually we see stabilization of disease. The drugs were approved based on decreasing of events of decreasing pain or decreasing fracture or such. And it really are not anti-tumor drugs. So after a period of time, and no one really knows how often these drugs are usually given monthly, how often they should be given once you're out there several years. So it's not uncommon after about 3 years that I may end up ordering the drugs maybe quarterly or such. There are other complications of these drugs. Brittle bone syndrome is something that we've seen where a bone will snap and just with no apparent warning. So we have a tremendous respect for these drugs. So they can increase the quality of life by decreasing bone fracture, bone events. They're not perfect. Certainly they're not anti-cancer per se.
Can I say something about that? So just kind of while we're on the subject of bone metastases, because we didn't really talk about it a lot. I don't know about the rest of the panelists here, but we have a pretty large cadre of patients in our 2,000 patients that have bone metastases, but we do not see it as a clinically significant shortener of the lifespan. Let me say that again. We do not see it, at least in our patients, that it has clinically shortened their lifespan. There may be some quality of life issues that have to be dealt with from time to time, but in fact, the majority of the bone metastases we see are painless. So then we have to figure out how do we control these bone metastases, because we don't want to have pathologic fractures and have a bone break at a spot where there's a metastasis. Calcium, vitamin D, vitamin C seem to also be part of the armamentarium in helping to protect the bones.
Thank you. This is for Dr. Ramirez. When a patient with lung net is being recommended for reasons of a carcinoid tumor, could you leave a patch in the lung with a chemo drug to help reduce any further development of tumors?
So a Chinese dumpling of the lung. So I do not know of any Chinese dumplings that we have ever used. There's obviously no data for the use of this. It's a novel idea which may be beneficial, but would not be done except under a protocol.
Thank you. Dr. Espinan. During cardiac stenting in the hospital, I received radioactive stents. I was knocked out for 6 months. Why, if only certain quantity is given? I think that means prevented from having any further radiation.
Yes, I'm prevented from, but I'm not familiar with the radioactive stents that you were given. Most of the time when we do cardiac stenting, the stent itself is not radioactive. A number of years ago, we actually worked with some of these that would cause the vessel to heal better, but I don't think we use radioactive stents anymore. They're one of those things that's, to my knowledge, it's not one of the things I have expertise in. If you'd like to talk to me afterwards, I'll try to figure out exactly what it was, because we do an awful lot of stenting procedures in the hospital. They have a tendency to be one of the higher dose procedures, especially if it's got to do something with vessels and so forth. Some of these radio-guided procedures are life-saving, and they do sometimes result in what's known as an erythema dose. Due to the fact that they're done under radio-guided procedures, the fluoroscopy actually builds up the dose on the skin surface, causing an erythema. And before we let you go back in and get another one of those procedures, we make sure that the skin's going to heal properly. It's similar to a sunburn, in the fact that the dose level has exceeded basically what would happen like you go out into the sun. And these areas actually become sensitive over time. So what usually happens is, in the case of EVARs, or if we have to go back in and re-stent, it's the same area that gets dosed a second time. And it's not necessarily the dose at depth that's the problem. It's the recovery of the skin that we went in on the first place from the fact that we did it under fluoroscopy. So we want the patient to recover before we go back in and actually do the procedure again.
Thank you. Dr. Anthony, how long do clinical trials last in general? And would our doctors know about clinical trials that may be helpful to our cancer?
So clinical trials will last a variable amount of time. Most therapeutic trials are open for the average of about 2 years. They will close when their accrual numbers are met, and the dates will be adjusted on how fast patients are coming in. So the clinical trials are designed to have so many people on each arm. Some trials will accrue very quickly, and then others might never accrue, and we call those trials go to what we call futility. So those are where the doctors voted with their feet. They didn't really approve the trial, they didn't like the trial, so they didn't put anybody on it. So we try to avoid those kind of trials, but in general, we usually don't open a trial unless it's going to be open for at least 2 years. Some smaller trials in the phase 2s are only going to accrue maybe 30 to 60 people. They may be open for less than a year, particularly if it's a real promising agent. Accrual is going to happen really quick. But what happens after accrual are people are followed. They're followed indefinitely in some cases. So each trial, when it formally closes to accrual, there's a period of people where people may be receiving treatment, depending on what's going on, and then they're being monitored. And that can go on for a number of years. For the AAA study for Lutathera, the company's been asked to give long-term chronic follow-up. What happens to people's bone marrow is 5, I don't know if they'll go 10 years, but certainly we would like to see long-term toxicity data.
And he's talking about therapeutic trials. You also have, if you have a preventive trial, could accumulate the same number of patients, and then there are really fast trials like imaging trials, which the patient's only in our gallium dotatalk imaging trial for 24 hours. Okay, Leanne, we're back to you. What do you suggest for those of us who have constant diarrhea to take for a bowel prep when about to have a colonoscopy or surgery?
That's, yes. I was about to say, that's a Dr. Boudreaux question, that's not a Leanne question. I'm gonna toss that one. I don't know what, if you're being cleared
Bowel
out.
prep light.
Very light.
Mostly clear liquids. Probably don't need much in the way of cathartics. Something very gentle if a cathartic is going to be used at all. So half doses or even third doses kind of thing or something like that would be my suggestion.
Okay, thank you. Greg, when we receive CTs, X-ray scans, does the age or generation of equipment in my small town determine the amount of radiation? Very good question. Mm-hmm. And is your new equipment better or safer than any other in NOLA? And how do I know the best, safest equipment for my scan?
Okay. I'm going to make a small pitch here for the people that I work with. I work with a bunch of radiologists. We hang around in the dark and do strange things. And you don't see radiologists too often, right? My radiology guys are up on, the American College of Radiology has a set of standards that they set across the United States so that no matter where you go for imaging, if you see that it's American College of Radiology accredited, they're limited to the amount of radiation they're going to give for their scans. They've actually sent phantom images and patient images, and they're going to minimize the radiation dose. It's kind of like every other place that you go to. If they're accredited and they have people like me who know what they're doing, it doesn't matter if it's a small town or a big town. I cover 14 facilities. Some of them are in little podunk towns where they do really great radiography. Because basically they're committed to the standards. So it is a crapshoot whenever you go, but if you see that ACR symbol that they're accredited, they actually tested to make sure that their doses were as minimal as possible in order to image, to provide those exams. Some of those who were lucky enough to live through Katrina were given all new equipment. It only took 10 years and swimming in the basement of charity. I don't recommend it for everybody in the audience, but for those of us who are willing to wait 10 years, yeah, we do have some nice equipment across the street. But just about any place that I go to as a physicist, they have some really high quality equipment. So you don't really have to worry about whether you're getting the best care anywhere. Even if you're in a small town, it may be some of the best available.
Dr. Boudreaux, in patients with extensive peritoneal mets, has there been any research into intraoperative chemotherapy? And is there any way to reduce recurrence after cytoreduction in the peritoneum?
You know, we've been struggling with that question for a while. It's a vexing problem. There is a therapy called HIPEC, hot intraperitoneal chemotherapy, that's done for other types of malignancies, where it's a recipe of a chemo soup that you put in the abdomen, close the abdomen, and you slosh it around in there for a while, and then you drain it out during surgery, and they stay on the table for a couple of hours for this treatment. The agents that are effective for those types of tumors, though, have not been shown to be effective for neuroendocrine tumors to date. We don't know enough to know about what a big dose of 5-FU all over the whole abdomen would do, and we're a little bit nervous about attempting that just yet. That probably would be the agent that might have the most promise unless we find a better mousetrap. But at this point, we don't have anything to that degree. What I'll do is I'll layer, when I do have a patient that has this carcinomatosis, I'll strip out as much of the tumor as I possibly can, and in the little bits and drips and drugs that are left, I'll layer another one of these absorbable sponges right on those areas to minimize recurrence.
Leanne, I like to have a drink made with 1/2 to 2 teaspoons of turmeric. If I am taking Afinitor, am I allowed to have turmeric, and are neuroendocrine tumor patients allowed to have turmeric in their diet?
Tumors occur. Afinitor usually has a side effect with more of St. John wort. I think that I'd have to go back, and I'll be glad to. You can email me. I'll go back and look at the literature before I give you a straight answer, because I think that in that amount, we might get into some, maybe some blood thinning effects. But to my knowledge, I don't think that there's any problems with it. And if your body, and if it doesn't cause, if it's something you standardly eat and it's not causing GI disturbances, there's, it would be fine.
And to the whole panel, this is a long-term question. Are there any efforts being made to increase the knowledge and understanding and recognition of neuroendocrine tumors for medical students and currently practicing physicians? I think for practicing physicians, Dr. Anthony just mentioned a training session that's coming up. The North American Neuroendocrine Tumor Society actually tries to teach all physicians, and in Iowa we're planning with NCAN a physician-patient conference that's going to happen next October. So I think NCAN, as much as anyone, is helping to train physicians. Medical students, I have to say, unfortunately, there are probably not very many of them who get much education unless the ones who come at Iowa to Tom Odorizio and Jim Howe's clinic get a very good education. And they're trying to increase the number of those students who get it. Any of you?
Certainly, at our institution, we have medical students and residents and fellows that come and rotate through us, and we really stress to them that they are at an institution where, which is unlike many other institutions where you could go do your training, to take advantage of that while they're here, because they're going to go out into community practice and may never see these things again, until they run into somebody with symptoms, and they'll think back and say, oh yeah, we diarrhea, flushing, yeah, I seem to remember something about carcinoid, and hopefully they'll know how to initiate the workup and then get them back to us.
We just had a recent experience of a patient who had 2 years of 15 to 20 stools a day, 2 years of living like this, and multiple admissions to the hospital with low potassium levels, was seen by 2 or 3 different gastroenterologists, and the primary care practitioner who we had interacted with some time back called us up and said, hey, I think I have a patient that might have carcinoid. What do you think? Sure enough, had a VIP OMA. They were close, but at least they were thinking neuroendocrine. So.
And I train dietetic interns, and they come through the clinics with me, so they're getting some exposure to it and the symptoms that go along with it.
You can spread the word too.
I'll just make one, we talked a little bit about the moonshot and things, but there's also a thing called big data. Physicians now in the future can put a patient's symptoms into their computer, and big data, Watson, particularly IBM, is getting a lot of attention there, will spit out the likely diagnosis. So I think humans are humans, and won't think of all the possibilities, but we're moving into the era where there will be a lot more technical assistance coming down the pike.
So you say we're going to be obsolete?
Can you repeat that
Artificial
question?
intelligence is exactly that. It's artificial. I think it really still takes a judge. I think we're artificial just as much as a judge and a jury in a courtroom would be artificial. Could it be replaced by some machine? I think you'll always have human interactions. I think you'll always have judgment, and none of that can easily be taught. It comes with experience.
Well said.
Okay, Lowell, you're on a roll. Here's another one, two more for you all combined. Are trials so selective that they only look for patients that are positive to the trial? And why are not all trials randomly selected? And how come failed trials are not published?
Okay, well, to take the last one first, there's a push right now where sponsors have to publish all results of all their trials, negative, positive. So this is part of their filing what's called an investigational new drug application, an IND. And so every IND put out by the FDA will have a reporting requirement associated with it. So that's more historical. Trials are really different. There's some types of subjects or of topics that you might think about is, would you want a coin toss to say, if it's tails, you go to the operating room, and if it's heads, you go on a Afinitor, or something like that you take, or you go home and do nothing. And I've not yet met the person that's willing to let a coin toss tell you whether you're headed down the pike for surgery or not. Have you met anybody like that?
Not too many.
Not too many. So surgery, if you take a surgical trial or any trial that maybe you think of ablative, and this might be where embolization possibly could be that way, people are already biased. So the surgical trials that are done are probably the ones that will never be randomized because it will go to futility. And I think there was an embolization trial that Dr. Chapman at Wash U put up, and it was a difficult trial to accrue to, and we'll hear that over and over and over again, that we put a lot of effort in setting these trials up. On the latest one was what the group did with adjuvant, which means after following surgery, put someone on a Afinitor, and that trial did not accrue at all, and it went to futility. So even though there's the best intent and an important question answered, how practical it is, it's where the doctors vote with their feet, maybe the patients, and I think that's what we're really wanting to look for. If we can empower patients that they want to support clinical trials, they want to know about it, they can have as much question and vote in it as maybe some of the physician staff.
Okay, here's a question for you collectively. What meds or foods need to be stopped, and how long before labs? I assume that's labs for measuring biomarkers. How soon before labs do they need to be stopped?
Well, we don't stop meds. The only thing that has to be held, if you want to measure an octreotide level or a lanreotide level, you want to draw it right before the shot is given. Otherwise, it won't tell you much, because you want to know what the trough level is right before the next shot. So, within a day or two or so of the next shot, before the shot is due, either that morning or the day before, whatever is convenient. Usually we have our patients do it the same day. They just go to the lab first to get their levels and things like that drawn. We don't stop the monthly injections prior to things like octrea scans and gallium scans and so forth, but we'd prefer not to give it the day after you just got your injection, because we don't know what the risk of having a false negative scan, because all the tumor sites are filled up with bland somatostatin binders, and the hot stuff doesn't go and stick to the tumor. So in general, you'd kind of like to do it right before your next shot rather than right after.
The question also had foods associated with it, what foods you stop. So if you're looking at 5-HIA, the urine, if you look at urinary 5-HIA, historically you put somebody on a serotonin-free diet maybe 3 days before. It's a little bit arbitrary. With the blood test, I'm not sure that there's actually a requirement for a serotonin-free diet in front of, So, labs, blood sugar, obviously octreotide will raise the blood sugar, so fasting labs there would help understand more about what is happening with possibly somatostatin analogs influencing that. What other labs that could influence?
PP is one that's more affected by food, but it never reaches, even with food, it doesn't reach the level of PP normal. And the only other one is substance P, which should be fasted maybe 4 hours before you do it.
So substance P, 4 hours beforehand, pancreatic polypeptide.
Be pretty much every time because it never achieves the level of action.
Okay, thank you. Greg, how much radiation would an average 70-kilogram adult receive during a 1-hour flight at 33,000 feet?
It's like a Wolverine question.
I like the easy questions. 4 millirem for each hour you're in the air. Now you want to put those into millisieverts? We just moved the decimal place, 0.04 millisieverts. Okay? So 4 millirem.
Did he pass?
Is that during the night or the day, or is it just during the day?
Anytime. It's outer space. Let's get there, Lowell.
It's not the sun.
Okay. Dr. Boudreau, if multiple primaries were removed during midgut resection years ago, and there has been no obstruction or seeding since, is it unfair to assume there are no primaries left?
Until we have some information to indicate otherwise, that's probably a good assumption. Speaking about that, I just this past week set my own new personal record for the number of primary tumors removed out of a length of small bowel. Want to guess what the number was?
104.
Now, those primary?
Well, depending on whether you want to call one of them primary and the other one a bunch of secondaries from lymphatic intramural spread, we don't really know. That one of the theories of how they get in the bowel all along is they drop off like metastases in transit along these lymphatics in the bowel. 155.
That was close.
And the most tumors I took out of a liver was 82.
I've seen them on scans.
That's a bunch. Yeah, they're walking
So
around.
when does it be like taking sugar out of the sugar cookie?
It's about like that. Takes a while. Interestingly enough, it was over about 110 centimeters of bowel, but there was over 400 centimeters of bowel remaining, and I was able to save the ileocecal valve. So that was big.
All right.
So
Here are two for Leanne. Is protein from lactose-free whey protein okay? And do you have a cookbook?
First is, yes, whey protein is fine, and it's really good. But protein supplements can be as easy, and probably the best one in the form, if you're lactose tolerant, is just dried powdered milk, just 5 grams in each teaspoon. Easy to find. I always tell people, go find somebody that's been on the commodities. It's probably sitting in the corner of their house. They've never used it, but it's very good, just plain old dried powdered milk. And no, I don't have a cookbook, but I do put out many recipes as a consultant for Novartis, for the Real Support Program, and I don't usually tell people that I write those, but they called me on and asked me to do a cooking demonstration for this one, so many of you may have seen me in front of the booth. One day when I have enough time, when I retire, or when I get enough time, and these guys aren't just working me to death, then I hope to do something like that.
Okay. Dr. Ramirez, would you recommend using a nano knife to remove small lung nodules?
So, Dr. Boudreau is much more familiar with the nano knife. I do not think, I don't think it is indicated in the lung, but he can correct me on this.
So the nano knife is not a knife. That's the first part. It's a series of needles. You need at least 2 needles because you got to have a positive and a negative, and you send direct current through those needles. Usually it's 4 needles to create a field. So one is positive and one is negative. Then it rotates and it goes positive to negative, then positive to negative, then diagonal across positive, negative, and diagonal across the other way, positive, negative. It kind of rotates around through the generator that zaps electricity. It's 3,000 volts for a nanosecond. And it's gated to the EKG of the heartbeat. So if it fires at the wrong part of the heartbeat, you'll cause heart arrhythmias and the heart stops, and that's kind of bad. Then it's like, now you got to shock the heart to get it going again because you just stopped it. So they call it a nanoknife because it's for a nanosecond. And that lightning bolt cutting through the cells punches holes in the cells, and they eventually kind of disintegrate and dissolve and die. Now, the problem with the lung is it's real close to the heart in a lot of areas. And so those experiments were done in dogs, and they all died. So I'm not ready to be the first one to try it in a human yet. Just saying. But, and the closer you get to the heart when you're in the abdomen as well, you have to worry more about arrhythmias just from scatter from electricity going around. So it's a very interesting tool. Placement of the needles is very critical. You have to get them exactly all parallel, right distance apart, exactly the same distance apart to the same depth. If one of them was a little bit off, then it screws up the impedances and the voltages don't travel right. You don't get complete killing and a bunch of other things. And it's all there placed one at a time by hand under ultrasound guidance. And so it's the tricky part is getting the needles exactly where you want them. And there was a question earlier about why don't you go after tumors bigger than 3 centimeters. It has to do with the flow of current in tissue and how far apart the needles can be and still get just outside the tumor and create that field that's going to zap them. So it's about the physics right now.
So the answer is no.
Right. Long answer to a short question.
Okay, so here's another one, Dr. Ramirez. This is about small cell lung cancer. What is your opinion regarding whether or not whole brain radiation should be done as a preventive measure for small cell lung cancer?
Yeah, so that's a very good question. So small cell lung cancer is on the very high grade spectrum of neuroendocrine tumors of the lung. It is primarily seen in patients who smoke, and it can be a very devastating disease because it is very fast growing. We generally will treat it with a combination. We break it into limited or extensive state disease based on the distribution of it. We treat it for, if it's limited, we treat it for curative intent, either with surgery up front followed by chemotherapy, or a combination of chemotherapy and radiation. Afterwards, and what the question was is about the role of prophylactic cranial irradiation. Now, whenever I put up a slide earlier about checking an MRI of the brain, and this is where we do this. We check an MRI of the brain to see if there's any evidence of brain metastases. Small cells notoriously spread to the brain. So what researchers have done is look at the role of prophylactic cranial irradiation or a lower dose of cranial irradiation in order to try to kill off any micrometastatic disease that we don't know is there. And it turns out that there is a benefit in doing PCI if you have no evidence of progressive disease. And that is not only in limited stage or curative intent, but also in extensive stage. So people even who you put through your 4 to 6 cycles of chemotherapy, and even though we know their disease has spread, we still give those patients, if their disease is otherwise stable and they look well, we still give them PCI because we know it decreases the risk of recurrence to the brain and also increases survival.
Dr. Espinel, 3 questions, but we've already answered a couple of them. So is radiation exposure from CTs, Octria scans, and all my other scans cumulative?
That's a very good question. Actually, we keep track of it on a cumulative basis, but one of the things I mentioned at the end of my talk is that our bodies are pretty amazing things. You didn't die from the first time you got a cold, you got over it, and you got an immunocompetence. Basically, you figured out how to deal with that. Your body repairs itself over time, and we treat radiation like it's a cumulative effect, basically to scare the hell out of you so you stay away from it. That's kind of joking. But the fact is that it's not really cumulative. Your body knows how to handle it, and over time it does the repair from the damage. In my career, I've worked nuclear power, I've worked in a hospital, and I have a cumulative radiation exposure that's probably comparable to yours. But it was something that over the last 30 years of working with radioactivity hadn't affected me in any way, and I've recovered quite well from it.
Right.
Dr. Anthony, please speak to how long octreotide acetate is usually effective, and do holidays help?
So octreotide is going to be effective indefinitely. So the question will be, are the levels or the amount you're getting adequate? If the tumor's growing or such, if there's a large amount of tumors there, the dose might be higher to control symptoms or not. So when the tumors start to grow, that's usually after several years for a midgut for a grade 1. So octreotide by itself usually is enough for, I'd say, at least 2 or 3 years. If there's a lot of disease there, more than half the liver involved, we may want to start debulking and not let the tumor grow in the first place. So there's a lot of judgment on the front end because we would like to maintain as low serotonin levels as possible, and so monitoring everything really kind of depends on how the disease is managed. So octreotide is just the backbone, or lanreotide, they're just the backbone of what we do. We get a certain floor effect where the serotonin levels just won't go any lower, and that's going to be dependent upon the amount of disease bulk. So holidays sometimes are helpful. It all depends on the situation. If people are not getting effectiveness from the depot formulation of these two agents, if for some reason it just stops working, in my practice that usually doesn't happen too much because I use rescue. If patients are having symptoms, then the rescue shots are provided early on, and it's an interpretation of how the rescue shots are working in proportion to the depot formulation. And if I see not a lot of benefit from the depot, I may drop depot and just be using the sub-Q in some cases.
And here's a follow-up question. Do you recommend checking the therapeutic levels of octreotide or lanreotide?
When these drugs were developed, levels were really not part of the drug development. We know that you don't have to have every receptor occupied. So the question is how many receptors do you need to be occupied to control symptoms? So the best question to ask is, are the symptoms controlled? And then the second question is the tumor control. So usually with those two things, we don't know specifically outside of what Dr. Woltering has told us about octreotide levels from his preclinical work in the lab. So until we have a definitive trial to prove that levels above certain amounts or end up with better outcomes. Maybe about 6 or 7 years ago, Gene came to me and he was convinced that his practice of using levels was the way to go. And my practice with about 120 certain, I use symptoms and tumor control to guide the dosing. And he was convinced that his outcomes were better than mine, but he never came back to me and showed me the data, so I assumed that was a negative evaluation.
Okay, maybe this is for Greg. Although it's not actually a radioactivity question, is there a contrast agent that is easier on the system and could help me avoid having nausea seconds after the injection?
We use two different types of contrast in radiology. One of them is a non-iodinated contrast, it's a little more expensive. It depends on what they're using to image you with. You may or may not. We also use a contrast agent in MRI, which is gadolinium. Some people have a reaction to it. Your best bet along those lines is to talk to your radiologist before you get the exam done to see if they're using which contrast agent they're using, because one of them's been out there forever and a day, and the one that's a non-iodinated one usually is sometimes easier for people to manage.
Okay, I have only a couple more questions. I apologize to those of you who asked a question for Dr. Fan. She wasn't able to stay. So here's one for Dr. Boudreau. Why are they not able to find the primary tumors, and what problems would happen if one was never found?
You said, why are you sometimes unable to find the primary? Because you can't. There are some entities that have been described as hepatic primaries and renal primaries in certain organs where what we assume is a metastasis is actually the primary tumor, and it's usually a diagnosis of exclusion because you don't find it anywhere else. There have also been cases where the primary has been found many, many years after the metastases have been resected. It was just so small that it was just not detectable at the time of the initial intervention, and then it finally becomes big enough to spot. So it's a kind of multifactorial question. We don't know how to look over every square cubic centimeter of a human from top to bottom, and so I'm sure there's things hiding in places that we just can't access yet and can't image. And so the best modality we have found so far, at least for abdominal tumors, is a hand scan. That you just go in there and you feel every centimeter of the bowel, and you check the pancreas very carefully by feeling it and ultrasounding it, and the liver the same way, and so on and so forth. And many times that's how you'll find the previously undiscovered primary. You had something to say?
Well, what you're alluding to is carcinoma of unknown primary, so we certainly do see neuroendocrine tumors of unknown primary. And so this observation goes well beyond neuroendocrine tumors. The hypotheses that are out there is why we can't find certain primaries. It may be that the immune system itself has attacked that underlying primary and got rid of it, and the metastatic sites that can evolve and mutate into be something a little different, maybe be under the radar of the immune system, might allow it to be persistent. But why that occurs, there's been autopsies done in these settings, and even at autopsies, you don't usually, if you don't see the tumor on scans or at the time of surgery or such, even in autopsies usually don't produce the adequate primary.
Leanne, do you recommend specific supplements for patients with carcinoid syndrome?
I am very specific with the ones I want you to avoid. The ones that are put on the market that are higher in sugar and high in fat that are used primarily for other areas of oncology can increase your symptoms. And those are many times the first ones that the oncologists or nutritionists that are not familiar with this will usually do. So supplements that are sugar-free are made for diabetics, where they use maltodextrin instead of a sugar molecule. Are better. So something that was put out for the diabetics would be better. And then something that's easy to absorb. So
what about the fat-soluble vitamins? Or even fat-insoluble vitamins?
Well, there's special vitamins that are out for fat-soluble for fat-soluble to improve your absorption of fat-soluble vitamins that actually carry over on a water molecule. And for patients that have severe steatorrhea, these supplements can be very beneficial. And they're available through, sometimes when you get some of your drugs, they even give them to you free. That's Aqua ADEK is one on the market, it's still on the market. And the other one that we used, I think, has been taken off the market now. The place where we see these are for patients primarily with cystic fibrosis. This is where the area that these things are used widely. But they also apply to y'all's population, too.
I would.
Okay, I'll only have two more. Did you have something?
I was just going to add to that the supplements. I get this question a lot of times from patients: what do you think about this supplement or this supplement? I heard about this on TV or on the radio, and what I'll say is we don't know. A lot of these supplements are not, or all of these supplements are not evaluated by the FDA. They're, you hear on their advertisements about clinically proven to do this, But I've yet to see a clinical trial based, a well-designed clinical trial that makes me say, all right, well, this is, you know, what it does, what it says it's going to do. So two things that I look for is, one, patients come in and they have some unexplained toxicity. I always say, all right, well, are you taking something new? What has happened? Why are your liver function tests elevated? And many times, oh, I started taking this supplement because I heard about this. So that's one. But two, I don't know what it's doing to my therapy either. Is it decreasing the efficacy of my therapy or increasing the toxicity of my therapy? So that is, I would caution you as far as some of the supplements out there, and just talk to your doctor.
Another note on that, I think of supplements two different ways. So the over-the-counter supplementation, supplements that are out there can also have an ephedrine in them as well. Ephedrine is very, very bad for patients having syndrome. I have a dietitian that works for football teams where they have to be very careful about what can be used. And they took 10 of them off the shelf, and all 10 said they had no of the items that were supposed to be ephedrine-based, and 7 of the 10 had them in it. So, and if someone tells you that this is going to help you, even if it's in your doctor's office, and they try to sell it to you, that's usually a red flag. And according to the American Cancer Institute, we do not use supplements to reduce cancer.
Okay, this is a big thank you. NOLA-NET team, thank you for bringing your numbers and your data. We knew you were good, and now we know how great you are.
That's you. That's you too.
Now if we can pull this off, this is a great way, I think, to end the session. We want a show of hands. Prior to your cancer diagnosis, how would you categorize your life? You have to answer, you have to raise your hand for A, B, or C. A is easygoing with minimal stress. B is average stress. And C was high external stress. Okay, so those who were easygoing with minimal stress before your diagnosis. Okay, 5. And average stress? That's certainly more. And high stress. So we're about the same for high and average. Now, this is for all of the people, all of the speakers, and what? Oh, now we have to have you answer another question. What is the #1 quality of life issue you face? So right now we're at stress level between medium and high before your diagnosis. And now what is the #1 quality of life issue you face? A, fatigue, B, diarrhea, C, pain, or D, something else. So how many of you, your greatest stress now or quality of life issue is fatigue?
Oh, fatigue.
Okay. Diarrhea. Maybe we should say diarrhea and fatigue. Okay. And C, pain. And something else.
Back pain. Back pain.
Okay. Now, for all of the panel members and any of you, any other speakers who are still in our audience, what can be done for fatigue?
Caffeine.
Dr. Odovicio?
It's important to check all 3 of the thyroid tests, because both lanreotide and octreotide in higher doses especially will give you a secondary low thyroid function, and that's one of the easiest things to fix. But you need all 3 of the functional tests. You need TSH, free T4, and free T3. And invariably, the free T3, the active hormone, will be the one that's low. And most docs, they don't pay any attention, but you must treat.
And Dr. Waltering.
You know, I gotta say that the number one thing that, if you ask my nurse, would I ask people what their biggest problem is? It's fatigue. By leave over diarrhea, flushing, wheezing. Goes along with those other stuff. I tried everything I could, and I do exactly what I would have taught me, which is measure pre-T4, T3, or pre-T3, and a TSA. That's rare. That is really pretty damn rare. About 1% maybe of the people that are fatigued have a result of thyroid issue that I can fix. Even my own mother, we tried on Ritalin, we tried on amphetamine, nothing worked. And I would love to know if somebody has an effective way to combat fatigue, because it's the number one problem amongst my patients.
And there was,
I'm going to say nutritionally, fatigue can be increased with concentrated sweets where your blood sugars are going up and then they bottom out in 30 to 45 minutes. So remember, that is also a cause of fatigue. So you have fatigue syndrome onset from concentrated sweets and all these little candies I'm sitting up here eating. And a low vitamin D. Vitamin D is one of the fat-soluble vitamins, and a low vitamin D can also cause fatigue as well. So, and not getting often feedings, although it may not be the cause of fatigue, you need a constant energy source, a small constant energy source. So I do encourage that as well. Rest, good sleep patterns. Vitamin D, and that's an easy test that can be run.
and you had another request?
Find somebody to repeat slowly the 3 thyroid function tests.
TSH,
3T4, 3T3, TSH.
TSH, free T3, free T4.
What was the third one?
You got those?
Give it a rest.
Okay. Dr. Wolin back there has something to tell us.
Radiation went to sleep at night.
He said this is a multidisciplinary question. Many things are involved that exercise, for number one, is important. There's actually a very interesting article about that in the most recent Time magazine or a week or two ago. He also said that depression is a very common problem, and for those of you who have small bowels, that you can have too much serotonin in the periphery and not enough in the central nervous system. So that's another reason you need multidisciplinary time. How do you balance the serotonin in the periphery? Dr. Wolin? I think, you know, in addition to taking the telotristat to decrease the serotonin production, that would be an interesting clinical trial, wouldn't it?
Hey, come up where we can hear you. There we go.
Welcome to Open Mic.
Come over here where you can get to the slide.
Oh, he's going to take over.
No,
Moving in.
Just real quick, the two basic ways of lowering serotonin are to stop production of the serotonin by getting rid of cancer. And whether that's surgical cytoreduction, embolization of the liver, PRRT, all those kinds of things that have less tumor, you have less serotonin. The other way of lowering serotonin is to use medications that will lower serotonin, which are the somatostatin analogs, which do a very good job of lowering serotonin, and also telotristat, which is going to be hopefully out within the next couple of months. So I think that we need to just do everything we can from every direction.
Okay.